You're live. Anabaran, you're live. You can talk.
Right now?
Yes, you're ready. It's already live.
Okay. Good morning. Thank you all for finding time and visiting today's webinar. Welcome to our second live patient webinar series. My name is Amreen and I am doing marketing management at LRH. I am the moderator for today's event, Patient Live Webinar, Bronchiectasis, Treatment of Lung, Mind, both hosted by Lung Rehab Voyage and Mind Vibes. This webinar is to create awareness among patients and carers about bronchiectasis and its management, Bio-Psychosocial model of care. Let me go through some housekeeping tips. Please check your audio and video. If you have technical problems, please first check the following basics. Is your internet connection stable? Is the upload speed fast enough? Are your headphones properly connected? Is the volume live appropriate? Are other programs running in the background that may be blocking the proper reception of the webinar, such as Skype, Viber, Teams, etc.? I hope you all connected well. Now put your phones on silence and tune your ears. This webinar is scheduled for 1.5 hours. Please type your questions in the chat box. Questions will be attended in last 10 minutes of the webinar. This webinar is live on YouTube and recorded version will be available in Lung Mind YouTube channel later in 2 to 3 days. Let me share the today's agenda. Our first topic is management of bronchiectasis, biopsychosocial model of care. For this speaker is Ms. Devi Sundar, founder and clinical director, Lung Rehab Voyage and Mind Vibes, Gloucester, UK. Our second topic is overview of anxiety and depression. For this, our speaker is Dr. Carolyn Nansubuga, Trainee Psychiatrist, Gloucester, UK. Breaks are planned for about 5 minutes between speaker, but if there is a need for additional time, please let me know. We will address some questions during short break in the presentation, and then finally we will leave time for a longer question and answer session. Now we begin. Our first speaker is Ms. Devi Sundar. Miss Devi Sundar, known as Shakila Devi Parmul, the founder of Lung Rehab Voyage and Mind Vibes, has working in the respiratory field since 2002. Early in her career, she has believed the connections between body and mind, developed passion for respiratory physiotherapy and psychotherapy. She has acquired double master's degree in respiratory care and psychotherapy. She has spent a large proportion of her career working at the St. Michael's Hospital group of St. Vincent University Hospital, Dublin, Ireland, where she gained valuable specialist experience in pulmonary rehabilitation as senior respiratory psychotherapist and pulmonary rehab coordinator. Patient recruitment, counseling, delivery of respiratory care, and research outputs on clinical practice. During her period in Dublin, she was keen in promotion and played a major role in development of patient education, video on pulmonary rehabilitation and self-management. She has also gained valuable experience in Lancashire Teaching Hospital UK as a clinical lead in home oxygen therapy. She has a great passion for knowledge conduction and worked as lecturer in cardiorespiratory physiotherapy and achieved a Fellow of Higher Education recognition in 2019. She had presented in over 25 conferences, Irish Thoracic Society, Chartered Society of Physiotherapy, European Respiratory Society, and chaired few poster sessions in European Respiratory Society. She has published over 19 conference paper and 3 full journal article in cardiorespiratory physiotherapy. Devi has excellent knowledge and experience of working with adults in COPD, asthma, bronchiectasis, lung cancer, ILD, and chronic lung disease, anxiety, depression, and mental health disorders. Provision of care for her clients includes airway clearance techniques, rehabilitation and exercise, prescription, breathing, pattern re-education, inspiratory muscle training, oxygen recommendations, promoting self-management, counseling, and psychotherapy. Devi set up Lung Rehab Voyage and Mind Vibes on her own in 2021 at the time of COVID to deliver a virtual, safe, detailed, and evidence based assessment treatment to patients. She commented a private practice by delivering a 3-day webinar on pulmonary rehab and mental health in 2021 June. She has keen to deliver free education resources and set up her Lung Mind channel and release about 32 videos on lung and mental health disorder management. So we know more about Miss Devi Sundar professional background. Now I invite Miss Devi Sundar to take the floor. Yes, Miss Devi Sundar.
Sorry, I didn't realize that there was a mute pressed there. So what I will be delivering today's presentation is to outline the basics of bronchiectasis, distinguish the different management approaches, and describe the bronchiectasis impact on the patient's biopsychosocial determinants, and to appreciate the importance of mental health in bronchiectasis management. So, as you be seeing in the slide at the moment, bronchiectasis is a chronic obstructive lung disease, and it is defined by the localized permanent dilatation of the bronchial tree caused by the destruction of the structural components like the muscle and the elastic tissues around the bronchi. So the primary insult is by the bacterial or the viral infection or the abnormal immunity, causing the inflammation in the bronchial airways, that resulting in the increase of the sticky mucus. As you can see in the picture, there is an image of our normal airway, and there is an image with increased mucus, purulent mucus, represented in a green color, and as a result of the infection and inflammation in the bronchial walls. I'm going to focus the prevalence in UK as I'm based in UK, and also the more of the guidelines will be relevant to UK based, the BTS and also the European guidelines. So it is estimated in UK around 1 in every 100 adults in UK have the bronchiectasis condition. And most recent study also indicate that there's about over 300,000 living with bronchiectasis, with awareness being created with more advanced diagnostic tools and management, which I'll be discussing down as we go through the slides. And there is also an indication that in Northeast England, for example, there's approximately, to give you an idea how severe it is, this prevalence is 1,200 patients with the diagnosis of bronchiectasis. And there is an unfair bias here with the bronchiectasis condition. Women are more affected than men, especially over the age groups of 50. And bronchiectasis condition is prevalent both in the child and the adults. And as I earlier described, what is bronchiectasis, where the pathology resides. The main pathology is in the bronchial mucociliary apparatus. So where is this, as you can see in the slide? There, as you can see in the slide, are a windpipe, which is the trachea, which is 4.5 inches long and 1 inch wide, is the connecting tube between our nose and nasal cavity and our lungs. Okay, and the trachea ends here, and then it branches into the bronchus and bronchi and bronchioles. Further, the smaller tiny tubes there, and they end up in the air sacs, that's the small pocket tubes there. And the air which we breathe in is traveling through the windpipe all through the way makes its way to the bronchi, bronchioles, and ends up in the air sac. And it is the end point where then the oxygen which we are inspired from the external source, that's the environment, and it is then getting transported into the blood and used for our survival purpose for different functions. So the pathology here in bronchiectasis, what we're talking about is these bronchioles, the bronchial walls, the internal tubes are infected and inflamed. What is there in the internal tube to get infected and inflamed? Normally, like when we inhale air, there is a mix of virus, bacteria, and other gases we inhale through the air. But we are blessed with a natural protective mechanism where internally in the bronchial tubes, there is an epithelial cells, and there is also a globule cells which actually secretes the gel layer and the cell layer, which forms the mucus. And you can see a small structures called cilia, and these are the small air-like structures which actually propels that, traps in all the viruses, bacteria, and propels that up towards a mouth. Either partly we put it into the esophagus and digest it into the stomach, or partly we spit it out. Okay, so what is this sticky mucoid substance contains is it contains some chemicals, some antibodies, IgA, immune cells, antimicrobial peptides, that is more efficient to destroy any bacteria or viruses. And normally the mucociliary escalator, which I'm talking about, this particular component here, this apparatus is a major barrier against an infection. And per day, about 100,000 bacteria would be actually inhaled trapped in, and that is then digested or destroyed by the bacteria, the mechanism which is there in our mucous apparatus, and then it is then propelled out. So this mechanism is impaired in bronchiectasis because of the viral and bacterial infection as a result of abnormal immunity or some unknown causes or some other causes which we'll be discussing. So as a result of this insult to the bronchial walls, there is inflammation in the tubes. And as a result, there is an impaired mucociliary clearance, and the airway mucus, there is an hyposecretion of mucus, and as a result, there is an obstruction in your airways. And this again led into more microbial colonization and infection. And further, the bronchial dilatation or airway obstruction happens, and the severity increases, and this goes about in a cycle. So as a result of this, what is the impact as a patient you're suffering is an impaired gas exchange, which is the ventilation perfusion imbalance. What it means is whatever the air or the oxygen in the air which we are breathing in is not transported enough into the blood because the mucociliary barrier is inflamed, and the attachment to the air sacs, if you remember the air sacs in the first picture, and the passage of the oxygen is impaired. And also there is an ineffective airway clearance, air trapping occurs, as we name it as a dynamic hyperinflation in clinical term, and there is an ineffective breathing pattern and a decreased expiratory air, that's the forced expiratory volume in the first second, and the activity intolerance. So ultimately, there is a huge impact due to the insult of the infection with the bacterial and viral on the mucociliary apparatus. As a result, you're not getting enough sufficient oxygen transported in the blood, and your organs are suffering with lack of oxygen. And also, there is a repeated infection causing repeated inflammation and bacterial colonization, which is the hallmark of the bronchiectasis. So, what are the causes? The most common causes in the UK around related to the infection is the whooping cough or pneumonia or tuberculosis, and a repeated infection due to COPD, chronic obstructive pulmonary disease. And the other common prevalence is allergic bronchopulmonary aspergillosis with an increased episode of eosinophilia. Some other causes are the alpha-1 antitrypsin deficiency, resulting in emphysema, a condition, chronic lung condition, and chronic obstructive pulmonary disease, COPD, asthma, and other causes might be due to obstruction, tumor, aspiration, trachomalacia, or immunity deficiency like hypogammaglobulinemia, and inflammatory conditions like inflammatory bowel disease, like ulcerative colitis, chronic disease, or rheumatoid arthritis, Sjögren's syndrome, interstitial lung disease, immunosuppression due to HIV is an example over there. And there is more prevalence of cystic fibrosis bronchiectasis, which is related to the CFTR gene mutation defectiveness, and there is a defective host mechanism like primary ciliary dyskinesia or carcinogenous syndrome. So these are some of the causes, and in this slide you can also see the representation, some of the conditions which I mentioned, which part of your lobe are primarily affected. Prominently, the cystic fibrosis or sarcoidosis affects the upper lobe, and the middle lobe, the aspergillosis or non-tuberculous bacterium, and the lower lobe with the aspiration, alpha-1 antitrypsin, and primary ciliary or rheumatoid arthritis. So what are the prominent symptoms? What these patients have is chronic cough, combined with a large amount of foul-smelling sputum greater than 500 ml per day. And the other symptoms are the shortness of breath, fatigue, hemoptysis, as a coughing up of blood, and chest pain and weight loss. The signs prominently, what we can see in any chronic lung conditions, and especially in bronchiectasis, is a clubbing of the fingers, the decrease in the angle in the nail bed, and also wheezing and thick pores, crackles in the base of the lungs. So what is the investigation? How can you identify, how can your health professional identify you have bronchiectasis and give you a diagnosis? Yes, chest x-ray might show some signs like tram-traxal ring shadows at the peripheries, but the hallmark, the investigation is the eye resolution CT scan, where you can prominently see the average diameter with more than the accompanying blood vessels, and the bronchoarterial ratio is greater than 1. And there are different types of bronchiectasis, where your bronchi is the normal bronchi representation and can appear cylindrical or in varicose shape or cystic. And I've given a representation of the varicose and the cystic, how the CT scan looks like. And the other investigations are the sputum test. Pseudomonas are the common identified bacteria there, Pseudomonas aeruginosa and Haemophilus influenza. And also there is a possibility of the non-tuberculous mycobacterium avium complexes. The other investigations are the blood test, serum immunoglobulin quantitative test, and the other marker of severity is the increased fibrinogen in the blood test. And also patients are referred for lung function test. As I already mentioned, there's a pathology. There is an obstruction of the expiratory airflow. So that is measured with the lung function test. And the bronchoscopy is done to take some culture samples. And there's also, if there is a possibility of investigation leading to CF, sweat chloride levels are referred to. And then there is possibility that primary ciliary dyskinesia is associated with the infertility due to immotile sperm. So sperm test is also referred in conditions with primary ciliary dyskinesia. And the other assessment of severity tools used prominently in wider UK is the Bronchiectasis Severity Index. And what actually it uses as a factor to identify the severity is it gets into a culmination of their clinical and radiological and microbiological features, like the body mass index of the patient and the percentage of the post expiratory volume in the first second and the previous hospital admission. And as the patient been hospitalized with a severe exacerbation in the past 2 years, or a number of exacerbations in the previous year, and the breathlessness score using the modified medical research council, and also identifying the bacterial colonization like Pseudomonas colonization. So identification of this bacteria and the sputum culture on 2 or more occasions, at least 3 months apart in a 1-year period, and that actually is a primary criteria included in the severity factor, or any other bacteria in a similar manner identified at least 3 months apart in a 1 year is included in the severity complex. And also it considers the radiological severity. And this predicts the 1 to 4 year of the morbidity or mortality of the patients with the non-CF bronchiectasis. And it also predicts the hospital admission and the exacerbation and the quality of life in patients. The other tool used is phase score, where it considers the FEV1 score, the age of the patient, the chronic colonization of the bacteria, and the extent of damage, tissue damage in terms of the lobes, extension of the lobes, and the dyspnea using the modified medical research council score. So the scores based on this, if it falls between 0 to 2 points, it's categorized as mild bronchiectasis. And if it falls between 3 to 4 points, it's moderate bronchiectasis. And if it is 5 to 7 points, it's severe bronchiectasis. So this is how it is scored based on the phase score. Now, let's move on to the management. A quick view of the management, because I'm not going to go in depth of each of the management. It's actually to create awareness to you with what is the current management, what you need to be including, what are the missing components. So the Bts Guidelines and the ERS Guidelines wider actually shout out loudly the goals of treatment as reducing the exacerbation, improving quality of life, reducing the symptoms, and improving the lung function, prevent the hospital admission and mortality. So there are some antibiotics that I mentioned in the slide, and these are common names which people who have bronchiectasis might be familiar with. So tobramycin, ciprofloxacin, aztreonam, and amikacin, gentamicin, and macrolide. So these are more common prescriptions. And also there is to improve the reduce the thickness of the mucus. There is a inhaled mannitol, hypertonic saline, and acetylcholine and airway clearance techniques and devices being used. And to reduce inflammation, some of the prominent usage is elastase inhibitors, PDE4 inhibitors, corticosteroids, and macrolides, although corticosteroids is not continuously being recommended. So what does the Bts guidelines actually say? The step one, it has a very structured way of step one and then progressing with the severity of exacerbation. So if a person is with acute bronchiectasis, then treating the underlying cause, airway clearance and pulmonary rehabilitation may or may not be, depending on the patient, and that's what the recommendations say. And I'll have my say later in the slide. And then there is an annual influenza vaccination and a prompt antibiotic treatment for exacerbation, self-management plan. And then if 3 or more of the exacerbation per year persist, then they're moving on to the reassessment and adding on mucoactive treatment to it. And if still there is issues persisting and the patient is not responding, then sputum culture antibiotic therapy is started with a inhaled anti-pseudomonal antibiotic rather than an oral antibiotic prescription. And then if it is not resolving, then they go into a long-term macrolides or alternatively long-term oral or inhaled targeted antibiotics. And if no pathogens is there, then the patient is given to long-term macrolides. And if it is not resolving, the patient is not responding to the treatment, then long-term macrolide and long-term inhaled antibiotics is followed. And if 5 or more exacerbation is persisting, then a continuous regular intravenous antibiotic every 2 to 3 months is prescribed to the patient. So antibiotics are basically used to treat the exacerbations and the acute deteriorations, like if there is a worsening of local symptoms like cough, increased sputum volume, or the change in the viscosity of the sputum, or the increased sputum purulence, which means that the first form foul-smelling sputum, with or without increase in the wheezing or breathlessness or hemoptysis or any other systemic upset. Now, if you remember the initial slide, which I showed, the vicious cycle as a result of the insult of infection and inflammation and dilatation of the bronchia. So the main treatment focus, as we just said in the guidelines, is correction of inflammation using usage of the antibiotics, bronchodilators, corticosteroids, and macrolides. And the cornerstone treatment is the airway clearance and pulmonary rehabilitation. And hypoxia, hypoxemia is treated with the oxygen therapy, and immunization and smoking cessation are the main targets for the prevention. And if there is a huge impact on the tissue damage, and surgery is opted. So how to monitor your exacerbation for antibiotics? How do I know I have exacerbation? If that's your question, then you have to look into the increased cough or wheeze presence and increased breathlessness than normal, because people with chronic lung disease get used to their breathing patterns and later might not be able to distinguish between what is a normal breathing and abnormal breathing. So whatever you perceive as your normal breathing, and if there is any difference in your in the past 3 to 4 weeks of breathlessness goes, then you have to categorize that as you have increased breathlessness and get aware of that might be a sign of an exacerbation. And increased sputum volume or change in the viscosity, increased sputum purulence, and systemic upset. So the strong evidence is there for the BTS, from the BTS and ERS and the Australian and New Zealand and Spanish guidelines, that airway clearance techniques are recommended and a respiratory physiotherapist advice should be sought. And individual airway clearance therapy is tailored to the patient needs. It's not actually a generalized, one size doesn't fit all. And so it is very, very important that you consult your respiratory physiotherapist and take a tailored airway clearance therapy. And also the adult with bronchitis and exercise limitation then should receive the pulmonary rehabilitation referral early on the stage when the patient is identified with at least when they identify with a moderate, they should be referred. What we see in a practical evidence in my practice before as a pulmonary rehab coordinator, and a small correction is I was a senior respiratory physiotherapist. There was a little bit of twist in that introduction. So in my capacity as a senior respiratory physiotherapist and pulmonary rehab coordinator, I've seen majorly the COPD patients with a component of bronchiectasis being referred at a very severe stage, a late stage, very minimal proportion of patients referred at a moderate stage. So my recommendations would be to refer the patient at the early stages when they get diagnosed with the bronchiectasis, depending based on the bronchiectasis severity index. And that might be the better tool to go forward and to categorize the patients to the pulmonary rehabilitation. And looking at the airway clearance, so there are several airway clearance techniques. I'm just going to mention it. I'm not going to go in depth detail about the airway clearance technique, which is not the purpose of this webinar. So just to create awareness, it's available there out there, and you consult your respiratory physiotherapist. The first airway clearance technique, what a patient would be given is active cycle of breathing technique, according to guidelines. And then if it's not, patient is not responding, and also it's some patients it will be tailored for pollution draining and postural draining. And if they are not responding to the postural drainage or the active cycle of breathing techniques, then the reassessment is done and then given an oscillatory posterior expiratory pressure devices, and the forced expiratory technique is considered along with it. And there are a variety of PEP devices, oscillatory PEP devices available out in the market. More advanced form is now the aerobicum. And while I was there, I'm talking about 16 years back, delivering my pulmonary rehab. So at that time, a cappella was there, and it was really a cappella and flutter was my prominent go-to tools at that time. And now, recent thing is the aerobicum is for supporting the airway clearance. What that oscillatory PEP device does is it has a small ball or the posterior expiratory pressure, and that is actually creating the oscillation that creates a shaking movement in your bronchial walls, and that loosens the secretion. And with the forced expiratory technique, then you're going to expel that sputum out, because you don't want it to load up that pus-filled infected sputum in your lung, which is actually giving a good flora area for the bacterial colonization. So you have to get rid of the bacteria. So that's the main basis of these devices given to you. And please do follow the recommendation from your physiotherapist. What we see in our practice is people don't consistently follow the recommendation of the airway clearance technique and end up in more hospitalization with the infection. And the other forms, individuals should be advised to complete airway clearance. The following order, if prescribed, is the first taking your bronchodilator, and then the mucoactive treatment, and then the airway clearance, whatever is recommended, and a nebulized antibiotic, so that your antibiotic is observed and treating the infection and the inflammation, and or the inhaled steroids to dilate if there is a rigid bronchioles. Okay, so this is actually the structure of the airway clearance according to the Bts Guidelines. And the lung rehabilitation, I've just put lung because I wanted to delivering this webinar to the patient, want to talk the patient language, the lung, rather most people might not be getting through that pulmonary rehabilitation. So lung rehabilitation, to make it simple, it is very much strongly recommended for people with bronchiectasis, because recent evidence by Ishani Patel in 2019 have proved that people with bronchiectasis have the same benefit as people with COPD in the fatigue domain of the chronic respiratory questionnaire. And patients should be referred to pulmonary rehabilitation at earlier stages. And my question now is, will our focus only on the antibiotics, airway clearance, and exercise improve the patient-related outcome? Is that true? My understanding is, with my passion in the body and mind earlier and now developed into lung and mind connections, when we are breathless, okay, or having that cough or the purulent sputum or pneumocystis, our patients are going through this culminative symptoms there in their life, which is a huge change from the normal pattern of their breathing. As a result, there is an increased work of breathing, use of accessory muscles, and dynamic hyperinflation, which causes them a feeling of suffocation in their mind. And the thinking process goes into an anxiety and panic attack, a misconception and frustration, and thoughts of dying. Okay, so there is a huge mental component involved in this disease process. As a result, there is a reduced functional activity, decreased conditioning of their chest and the extremity muscles, and they self-isolate because they cannot perform or not able to perform the activity or be functional as before. So they go through a roller coaster of feelings and emotions like denial of the disease process and angry with themselves. Why did they get it? And how they're going to make their living and work their relationships, work the relationship with themselves, with their work, with their partner, with their kids or sibling, whatever it is. Okay, there is a huge component of anger. Why are they in that state? And there is a lot of bargaining. What life things they need to be compromising to lead a normal practical life, and they fall into a lost component of their future because they are more perplexed whether their condition prognosis is going to be worse, and they go into depression states. And finally, after all of these, at one point they might be going into acceptance and with some denial, and that might not give them an improved quality of life. So are we missing the connections now? So hope it's clear. Yes, all the guidelines, all of the management process or approaches here by the guideline societies, the respiratory societies, are focusing on the biological component of the disease. That is the pathology, the disease process, symptoms, and the doctor's tests and treatments. But what is that making sense of my psychological and social benefits? What is that outcome I'm going to receive as a result of these treatments? Okay, because I'm going through depression, stress, guilt, anxiety, identity issues, and cheers, and a social burden, the career, because people who are disabled to a severe category might not be able to work, and the financial burden, their friends and family relations, and hobbies. So the medical support keeps me alive, but it is the psychological and social support that enables me to live. So our focus should be focused on making the people to live, not to keep them alive. We only talk about the morbidity and mortality rates. We don't talk about the patient-related outcome. We don't talk about how they're able to live, coping mechanism, how the support systems around them, how they are feeling about themselves, how they're relating to the family, relating to the job. Yeah. And this is internally going to impact the economy of their country, wherever they are living. Okay. So let us then go into details about counseling and psychotherapy. So psychological component, which spoke about earlier, the thought process of their illness, the future treatment, and their future, and the self and the relationship. And as a result of the physical symptoms like pain, sleep troubles, and fatigue, and low energy, they actually avoid certain behaviors or do less or more of certain behaviors. The prominent two psychotherapy tools I've just listed on the slides, which I'm applying to my patients, is the cognitive behavioral therapy, where the basis is the thoughts, exploring what their thinking affect their feeling and acting, and explaining about what their behaviors, what they do affects how they think and feel, and explaining about the emotions, what they feel affects how they think and act. Okay, so these perceptions are discussed with the patient, some elaborate questions and some strategies and tools to apply, and that helps them to change the perception and use some strategies to handle the current disease process and help them to live an improved quality of life. And the next one I would like to mention is the acceptance and commitment therapy, where this is based on the psychological flexibility, which I love, this acceptance and commitment therapy approach, where it has 6 components in it, where considering making the patient to consider themselves as a context. Okay, so observing the self. Okay, getting aware of their thoughts and behaviors and moods, and then diffusing the thoughts more in a healthier way by observing the thoughts, and without no judgment, without no cognitive distortions, okay, and detaching from their thoughts, and then opening up to whatever comes to them. Acceptance and willingness, that is the very first thing anyone need to do if they are in a crisis, okay. That applies same to the disease process. And then contacting with their present moment, being in the now, the present moment. And how they do this is, we talk about their values, and we explore them with the different questionnaires about their values, and make their values more important, and link them with the committed actions, what they can take, and effective physical and mental actions guided by the values. So these are the two prominent things, and I would just strongly recommend to go to your nearby counseling or psychotherapy units, or avail some NHS counseling and psychotherapy units to manage and cope with your bronchiectasis in a better way. And so now the prevention or the self-management, widely we know that immunization and taking your medication regularly, the antibiotics and regular checkups, and doing your breathing, the lung function tests, sorry, and also to focus on smoking cessation if you have the smoking cessation, and having healthy habits like doing a regular exercise, healthy foods, being hydrated, and doing some yoga or mindfulness, and attending some counseling and psychotherapy sessions to improve your anxiety and stress and panic and depression related to your condition. And I could not end the session without talking more about, although this is a one slide, but it is more very important. I would like to emphasize the importance of this slide here, the palliative or the end of life care for patients with bronchiectasis. So this is basically to the advanced or severe stage of bronchiectasis, where they actually related to the shortness of breath, anxiety and sputum production, and relating to improving their quality of life. So prominently the methods followed there is use of fan, benzodiazepine, and narcotics and anticholinergics to decrease their symptoms and improve their quality of life. In advanced cases, it's very important. The health management directive is consulted and developed in consultation with the patient and the family. To manage exacerbation, and what are the steps they can go forward for, and the referrals of social support. And recently there is a more advanced awareness about the social prescribing and the support system available. So that is another option to include in the palliative and end of life care. Now, if you're unsure whether you qualify for hospital admission, and it's very important in this pandemic of COVID climate, if you have any cyanosis or confusion, or if your respiratory rate is greater than 25 per minute, and if you circulate your respiratory failure is present there, and if your fever is greater than 38 degrees Celsius, or if you fail to improve 7 days of your oral antibiotic therapy, or if the disease is impaired severe forced expiratory capacity, that is less than 40% predicted, or if you have a limited support in your home and have a difficulty to follow up or review, if you have any learning disabilities, and if you have any other new onset of self-care needs, then definitely you have to knock the doors of the hospital and seek more attention for your condition management. And I would like to mention briefly here, there is a recommendation for traveling with bronchiectasis, and this recommendation has been populated wider, and it is formed by the ELF, European Lung Foundation, EMBARC, and ERN Lung Collaboration. So what all briefly to mention a few important points is, if you're making yourself heading away for exploring the world, and if you have a bronchiectasis condition, please do consider not to book any high altitude destinations, and carry all your medication. Don't forget to take your health insurance, and also if you have a European disability card, do carry along with that with yourself. And also choose a location where there is a nearby bronchiectasis unit, where if if your severity of symptoms gets more severe, so that you can immediately go and knock the doors of the medical professionals for the management. I just briefly mentioned here, and there are loads of other important recommendations for people who are traveling. So I would highly recommend to click this link, and later this video will be populated in the YouTube, and I can mention the link and in that space as well, so that you can go and click that link. Now, so when I started up this slide, I was talking about a lot of things, which was a normal management focus according to guidelines, and my topic was Bio-Psycho-Social model. I did actually explain now what is the psychological and social component, what we need to include. So then now I corrected that initial flow diagram into, yes, we are going to attend all the correction of inflammation stuffs there. Yes, we are going to go into the airway clearance, pulmonary rehabilitation, oxygen therapy. But the inclusion here is the counseling and psychotherapy, the CBT and the ACT, and along with other management, the immunization, smoking cessation, and one other important inclusion is the health management directive, the palliative or the end of life care. Now, I would like to share with you a patient story to give you an awareness about how a patient living with bronchiectasis feels. So let me actually...
Before I was diagnosed in 2010, I was very physically active. I worked in the fitness industry. I was exercising daily. That has changed dramatically. I was ill for around 9 months with a series of infections ranging from bronchitis through pleurisy and pneumonia. Eventually I was admitted to hospital and was in hospital for a week before I was diagnosed with bronchiectasis. At that time I was told that it is degenerative, there is no cure, it will get worse with time. I went through a range of emotions, from being angry to the why me to the okay, let's do something about it. The greatest challenge since being diagnosed has been to slow down. Life is no longer 100 miles an hour, and actually that's quite a nice thing. My healthcare practitioners have been very supportive in listening to me, listening to my suggestions, listening to the ways that I want to address the condition, and they've been very supportive in allowing me to develop my own exercise regime, my own nutritional plans. They've been so supportive. They are happy to allow me to climb Kilimanjaro, so that's a bit of a big risk, but they're willing to help me do that. I use a device to help strengthen my lungs. It causes resistance when you breathe in and out. Basically, it makes the lungs work harder and improves the strength of them and improves the capacity as well. To health professionals that want to provide good support to their patients, I would say try to think of them as individuals, not as a case with a condition. Each individual is different. Things work differently for different people, particularly when it comes to managing a condition, and exercise is always different for every individual, as is nutrition. I think that patients should be involved in their treatment plan. I think that they should be able to make suggestions. I think they should be able to ask questions. Appointment times are very short. You can't cover everything. So it is good for the patient to be in control of what's happening to them. When I was first diagnosed, I was given various medications, specifically steroids, daily antibiotics, mucus clearance tablets, and at times various other medicines to help fight infection. Generally, I had more side effects than benefits. So after a period of time, I requested to take some medicine holidays, which has now resulted in nearly 2 years of a break. My hopes for the future are that there will be more research in bronchiectasis. I would hope that within that research they would find better ways of treating the condition rather than medication. I would hope that they would find better strategies for treating patients and for patients to be involved in their self-management.
So now we come to the end of the slide. Thank you for listening. So please share your questions and comments and thoughts on the Lung Mind channel if you're not able to share any at this time or this occasion. And I've listed the email ID and the website, so do visit our website. And we also have a Facebook, so you can actually put your comments and show your support over there. And we'll be back on our next series webinar soon. And thank you again. Have a good day.
Thank you, Ms. Devi Sundar. Any questions for next 5 minutes? Now move to our second speaker, Dr. Carolyn Nansubuga. Dr. Carolyn trained as a doctor at Makerere University and after working in Uganda for 5 years, moved to the UK to pursue her career in psychiatry. She is currently working as a trainee psychiatrist in the UK. She is interested in empowering women to reach their best. Now, Dr. Carolyn will take the floor.
My name is Dr. Carolyn Nansubuga. I am a psychiatry trainee in Gloucestershire. I'm currently working with Gloucestershire Nhs Trust, and I'm very passionate about mental health awareness. So today I want to talk about anxiety and depression in chronic disease. If you have any questions, please feed them back in and I'll be able to answer them in after the presentation. So I'll start with the definition of anxiety. What is anxiety? Anxiety is generally that feeling of unease, like there's impending doom, something bad is about to happen, you know, that worry you have constantly that something is about to happen. And normally anxiety is a normal feeling. Everyone goes through the motions of anxiety from time to time, when you're in a new environment, when you're starting a new job, and it's generally supposed to be a normal feeling. So when does it become abnormal? It becomes abnormal when the worry becomes excessive and it becomes generalized. It's about everything that happens in your life. It can be about your children, you worry about your work, you worry about everything, and it's really, really excessive instead of worrying about one specific event. So in that case, we then call it generalized anxiety disorder. And just like the definition, generalized, it's worry about everything. You find some people saying so-and-so is a warrior. They'll literally worry about every and even the smallest thing that happens in their life. They'll worry excessively. Now, most times it has been shown that generalized anxiety disorders is usually comorbid with depression. They happen at the same time. And depression is, the definition of depression is basically a low mood that lasts for weeks or months and oftentimes starts affecting your daily life. Now, I'll go on to talk about how common these two conditions are. Now, anxiety disorders have been shown to be the most common psychiatric disorders in the UK. Literally 5% of the UK population is affected with anxiety. And that's why we are out there to create their awareness, so people know that what they're experiencing is either normal or is actually starting to get out of hand. Anxiety disorders have also been known to be the most common in people who are elderly, and the prevalence ranges between 1.3 to 4.7% in the UK population. And generalized anxiety disorder in particular is most common with between working age adults, people who are between the ages of 35 and 55 years. And it's interesting that 2/3 of these people are actually women. We women are known to be natural warriors. We will worry about the kids, we'll worry about the home, we'll worry about our husbands, we'll worry about our workmates, and we can go on and on. So, as I mentioned in the previous slide, generalized anxiety disorder and depression are frequently comorbid. And by comorbid, I mean they frequently occur together. It is not unusual to find someone who has generalized anxiety disorder and they have depression as well. Now, what are the risk factors for anxiety disorders? I'll try to narrow down this in line with the theme for today. And the theme for today is chronic conditions, and like the lung conditions we are discussing today. Bronchiectasis is one of those things that you actually qualifies to be a chronic condition. So having a painful long-term condition can predispose you to having anxiety disorders and depression, because generally there are so many things that happen when you have a chronic painful condition, or just generally a chronic condition like cancer, people who have had accidents, people who have had all sorts of traumatic experiences. These things predispose you to having anxiety and depression. Then for some of us, we inherit the genes from our parents. My mom or my grandmother could have been a warrior, and I cannot help it because they passed on the genes to me. So I have that tendency probably to be a natural warrior. And some people are generally like that. Then for some people, it's just generally a chemical imbalance in your brain. And the chemicals I'm talking about are serotonin and noradrenaline. Now, these two chemicals play a major role, and we'll see that when we go to talk about the medications later on. Then sometimes it's just because of an overactivity in particular areas of our brains that are involved in the emotions and our behavior that predispose us to having generalized anxiety and depression. And please note that there are people who actually develop generalized anxiety disorder or depression for no apparent reason. They've not had any traumatic experience in their life. They've not had any trigger whatsoever, but then they develop these two conditions. Now, what are the symptoms? For anxiety, it's just generally that feeling of being restless and worried, like that fear of impending doom, the fear of impending danger, you know. And in addition to that, people who have anxiety disorders, they will have troubles concentrating on things they normally do from day to day. They will have trouble sleeping. And in some worst case scenarios, some people might have actually dizziness or heart palpitations happening from time to time. Anxiety disorders are quite many, but I'm narrowing down to just generalized anxiety disorder. Then when it comes to depression, people have a tendency of having a low mood from time to time. Then they tend to stop enjoying things they naturally enjoyed. For example, someone probably used to enjoy taking walks, and over time you realize they keep to the house. They no longer enjoy taking walks. They no longer enjoy doing their hobbies. then you start worrying about that person. They could probably going through a depressive phase. Then sometimes there's a feeling of hopelessness, like there's nothing, you don't have anything, you're worthless, you're feeling hopeless. And then as it gets worse, you'll probably end up not being able to concentrate on everyday things, for example, cooking or juggling the things that you do from day to day, taking kids to school or going to work. You tend to realize that there are lapses in the concentration that you normally have. Then in the worst case scenarios, some people might actually have feelings of wanting to take their lives or feelings of wanting to harm themselves. And if this is happening to you, please reach out. There's a crisis telephone number that I'll probably link in the description box once we are done with this presentation. Now, I will go on to the treatment. In early stages, the best thing to do is to carry out self-help activities. And part of self-help involves having a healthy lifestyle. And by a healthy lifestyle, it goes on to say exercise regularly, eat healthy, eat a balanced health diet. If you drink alcohol, cut down on your alcohol consumption. If you smoke, think about stopping smoking, especially with chronic lung disease. We highly encourage you to stop smoking as it makes your condition even worse. Then we encourage people to practice mindfulness. Mindfulness has been shown to increase people's well-being, it lessens the anxiety level and helps with depression. And then most importantly, seek out the support systems around you. Talk to a friend, talk to family, talk to a co-worker. And if you have no one to talk to, reach out to your GP or reach out to the NHS. There's a helpline where you can actually ask to speak to someone without referring yourself to the GP. Now, in terms of the actual treatment, psychological therapies have been recommended by the Nhs Guidelines as the most important and the first line in managing anxiety and depression. You can get these therapies on the NHS, and the commonest that we normally give is cognitive behavioral therapy. And this has been discussed in detail, so I will not go into detail about this. Now, we as the psychiatrists, we are here to do the other bits, which is the pharmacological therapy. And by the pharmacological therapy, I'm talking about the medicines that will help with your anxiety or depression. Now, I'll talk a little bit more about the medications. So the most common medications we use in anxiety and depressions are what we call selective serotonin reactic inhibitors. Now, these medications are very good for managing both anxiety and depression, but they have to be given on prescription. You have to see your GP, who will probably end up referring you to see a psychiatrist, who will then prescribe for you these medications. So there are a few things you need to know about these medications. These medications are normally effective in treating anxiety. However, they have some side effects that you might experience. So if you experience these side effects, please don't stop the medications, because sometimes the side effects stop after a particular amount of time. And what are the side effects? The side effects normally include, you may start to feel on edge, what we call agitation, in the beginning stages of taking the medications, or you start having some unpleasant symptoms like tummy pains, nausea, you may feel like vomiting, but all these on your kind of initial stages, and over time they'll go away. Now, there's something you need to note. When you start these SSRIs, please do not stop them on your own, as there's a danger of developing a very big side effect called the serotonin withdrawal syndrome. So if you want to stop your SSRI and you've been started on it, I highly recommend go see your GP so that they help you to stop this in a safer way. Signs of these withdrawal symptoms are common as well, and they also include tummy pains, nausea, pain, but all this can be avoided if you go see your GP when you plan to stop the medication. Now, I initially talked about how to get help and where to get help if you have anxiety and low mood. The easiest and the best way that is most accessible for most people is to reach out to your GP, and that is easy. Just call your GP and tell them how you're feeling, and they'll be happy to help. Well, some people, when they're feeling so low and depressed, they do not even have the energy to refer themselves to the GP, but you can actually refer yourself directly to Nhs Psychological Therapies, such as the IAPT, without needing a referral from your GP. With this therapy, then you'll be able to get to access talk therapy. But in worst case scenario, if you're experiencing things like wanting to end your life, if you want to harm yourself, please call 999, because at that point we consider you as a person in crisis. If you are a person in crisis, please go to your A&E or call 999 and there will be someone to help you. Thank you so much for tuning in. Thank you so much for watching this presentation. I'm passionate about empowering people to be mentally healthy, because health is described as a complete state of mental and physical well-being. And my passion is to make sure that we achieve that complete state of being healthy. Below are some useful links that you might want to click on. And some of these links also have particular links you'll be able to click on if you want to seek help, and they'll lead you to more useful links. Thank you for watching, and please don't forget to subscribe to our channels, and please don't forget to leave in questions. We'll be happy to answer them at the end of the presentation. Bye.
Okay, great. Thank you all. We appreciate you being with us today. We care about your opinion. So please communicate your comments in the chat or Lung Mind YouTube channel. Thank you again for attending today's webinar. We encourage you to connect with us on social media, Facebook, Lung Rehab Voyage. If you have additional questions, you can contact us by email or telephone number. Email and telephone number are mentioned in the description box as well as chat box. We are happy to provide additional support. We do offer free 15-minute consultation. Check out our website www.lungrehabvoice.com.